All right. Good day, everyone. My name is Onori Victor. I am a neurology applicant, and I will be doing the Ching Cheng's comprehensive review in clinical neurology. We've done questions 1 to 7. Our last episode was pretty short. We did just questions 6 and 7, and that's because I was trying to watch the time. We hit the 12-minute mark, so I decided to call it a day so as to prevent people from getting bored. So that's the same thing I will do. Once we reach the 12 minutes mark, I'll just call it a day. Let's begin with question 8. A 69-year-old woman presents to the emergency department at 2 hours and 35 minutes from the onset of left hemiparesis and hemineglect. Her NIHSS, that is the National Institute of Health Stroke Scale score, is 12. A brain CT scan shows no hemorrhage. Which of the following statement is correct regarding IV tissue plasminogen activator TPA? A. The risk of hemorrhage with TPA is similar to placebo. That's so false. The risk is not similar to placebo. The risk is there and it's very, very real. B. Early administration carries a better prognosis and a lower risk of hemorrhage. That is true. The earlier you give it, the lesser the risk of hemorrhage and the more the prognosis. C. There is no maximum dosage. That is false. The maximum dosage for outer place is 90 milligram. It's given at the dosage of 0.9 milligram per kg, and the maximum dosage of the nectar place is 25 milligram. It's given at 0.25 milligram per kg. Options D. The use of TPA improves short-term but not long-term clinical outcome. That is false. It improves both short-term and long-term clinical outcome. And options E, TPA should not be administered beyond 2 hours from the onset of symptoms. That's false. Ideally, it should be given within 3 hours, but you can extend it by 4.5 hours. So let's do a brief talk about this. Now, TPA, which is tissue plasminogen activator, is a thrombolytic agent and it is used intravenously for the treatment of acute ischemic stroke. Early administration, like we said earlier, correlates with the better prognosis and lower risk of hemorrhage when compared with later administration of this medication. The TPA for acute ischemic stroke trial was published in the year 1995 and performed by the National Institute of Neurological Disorder and Stroke (NINDS) study group. And in this trial, IV TPA was given to eligible candidates or patients with acute stroke within 3 hours from the onset of symptoms. These patients were given 0.9 milligram per kg of the drug with 10% as a bolus and the rest over 1 hour, and the maximum dosage was 90 milligram. Symptomatic intracranial hemorrhage occurred in 6.4% of patients who received intravenous TPA compared to 0.6% in those who received placebo. The time window from symptom onset to allowable time for TPA administration was 3 hours. However, it was determined that the earlier the administration, the better the prognosis and the lower the risk of hemorrhage. Patients who received IV TPA had improved clinical outcomes and were at least 30% more likely to have minimal or no disability at 3 months. And the mortality at 3 months was 70% in the TPA group and 21% in the placebo group. Administration of intravenous TPA is indicated in patients with an acute ischemic stroke presenting within 3 hours from the onset of symptoms when no contraindications are identified. And based on the European Cooperative Acute Stroke Study 3, ECASS 3, the use of TPA between 3 and 4.5 hours from the onset of symptoms have been shown to be beneficial in selected patients. However, four exclusion criteria, which are relative contraindications, exist. They include NIHSS score of greater than 25, age more than 80, history of stroke and diabetes both occurring at the same time, and use of any anticoagulant regardless of prothrombic time or INR. Now, question 9. A 72-year-old woman with a history of diabetes presents with transient visual disturbance on the right side. On further questioning, she reports that she experienced a transient dimness of the vision of the right eye, progressing from the upper visual field to the lower visual field like a shade falling. This lasted for about 10 minutes and resolved on its own. Which of the following is correct? Now, this is hitting me like a classical picture of Amaurosis fungus, which we're going to talk about shortly. Now, to understand this, we need to know about the blood vessels that branch off from the ICA. The retinal artery actually originates from the ophthalmic artery, which itself is a branch of the internal carotid artery. Transient occlusion of the retina or the ophthalmic artery may manifest as amaurosis fungus. Amaurosis fungus is often described as a painless visual loss, and classically, the patient describes a shade or a curtain that moves down in a vertical plane with rapid onset and brief duration for about a few minutes. Vision is most commonly recovered completely. However, the presentation of amaurosis fungus in a patient with an underlying ICE stenosis may herald the onset of a stroke. For this reason, when a patient complains of amaurosis fungus, investigation should immediately be obtained to rule out carotid stenosis and establish appropriate treatment. Other rare but possible causes include things like giant cell arthritis and embolism from other sources. Now, it's important for me to add this clinical pair, and that's the fact that whenever you have a patient who presents with visual symptoms, it is actually very important for you to obtain detailed information to determine if the visual phenomenon involves the eye or the visual field. Now, a visual phenomenon only affecting one eye is in general most likely an ocular problem. But if you have a visual phenomenon that affects both eye, then it's either in the visual pathway or the visual cortex. So back to our question, we have the options. Options A: this patient is having a transient ischemia of the left occipital cortex. That's false. B: a transcranial Doppler would demonstrate increased velocity in the basilar artery. That makes no sense. C: the right IC is stenotic with an atherosclerotic plaque. Remember, we said that usually whenever you have an amaurosis fungus, you have an issue with the ipsilateral ICA, so that is correct. D: the left ICA is stenotic with an atherosclerotic plaque. That's false. And E: fundoscopic examination would demonstrate papilledema. That's false. So option C is the answer. So on to the next one, question 10. A 40-year-old man presents with tinnitus, unilateral hearing loss, nausea, vomiting, vertigo. Before we go on, let's localize this symptom. After tinnitus, ringing sensation in the ear, we have unilateral hearing loss, cranial nerve 8 is gone. We have nausea, we have vomiting, we have vertigo. Okay, on examination, he has nystagmus, he has ipsilateral ataxia, ipsilateral Horner syndrome, contralateral sensory deficits to pain and temperature of the arm, trunk, and leg. Which of the following is the most likely diagnosis? So, going by all this, we are looking at a lesion somewhere in the lateral pons. Yeah, and this is a lateral pontine syndrome, which is caused by an AICA stroke. That's anterior inferior cerebral artery. Let's talk a little bit about that. Now, the clinical presentation of anterior inferior cerebral artery, in fact, is variable, and it may be similar with that of a posterior inferior cerebral artery, that's a pica stroke, aka the Wallenberg syndrome. However, the difference is the ipsilateral deafness that occurs in AICA, in fact. The reason why we have deafness in AICA, in fact, is because of the involvement of the labyrinth artery, which is in fact a branch of the AICA. And an infarct to the labyrinth artery will cause inner ear and cochlear injury. So that makes AICA to be correct. So that's been said, I think we're done with this. See you in the next podcast.